Good morning. I would like to call this meeting to order. Katie, would you please call the roll?
Mary Ellen Early,
Present.
Ray Hernandez,
Present.
Dr. Maheta,
Present.
Sam Kabushian,
Present.
Michael Terry,
Present.
Sarah Williams,
Present.
Vice President Goldstein,
Present.
and President Guzman.
Present. Thank you, Katie. The quorum is present. I apologize. I'm going to have a loud truck come by. Okay, here we go. My opening remarks. I want to ask everyone to please turn your cell phones to silent. This is an official business meeting of the Respiratory Care Board. You may notice the board members accessing their laptops, phones, or other devices during the meeting. They're using the devices solely to access the board meeting materials that are in electronic format. Public comment will be allowed on each agenda item as each item is taken up by the board during the meeting. Under the Open Meetings Act, the board may not take any action on items raised by public comment that are not on the agenda, other than to decide whether to schedule that item for a future meeting. If you would like to provide comment, it would be appreciated, although not required, if you would provide your name and the organization you represent, if applicable, before you speak. To allow the board sufficient time to conduct the scheduled business, public comment may be limited. The board welcomes public comment on any item on the agenda, and it is the board's intent to ask for public comment prior to the board taking action on any agenda item. If for some reason I forget to ask for public comment on an agenda item and you wish to speak on that item, please let the moderator know and you will be recognized. Are there any comments or questions from members at this moment? Seeing none, moderator, can you please instruct our audience how to make a public comment?
Absolutely. When we are ready for public comment, I'll display a screen as you see before you. I'd like you to tap that hand button at the bottom of your screen to raise your hand. Dial-in users will need to dial *3 to raise a hand. And we will take comments in the order that they are received. People will be given 3 minutes to speak with a 30-second warning. If you are having trouble with raising your hand, or you have a concern that I can address directly outside of the board communications, there's a Q&A box in the lower right-hand corner of the screen where you can ask a question and I will answer it as best as possible. This feature is best used for technical support. If you'd like to make a comment, raise that hand. All right, back to you, Mr. Board President.
Thank you, moderator. Do we have any public comments at this time?
Which agenda item are we taking public comment on, please?
Just on my remarks.
All right, we are taking public comment on Board President remarks. If you'd like to make a comment, tap that hand button at the bottom of the screen to raise your hand. Dial-in users dial *3 to raise a hand, and we will call on people in the order we have requests. We're going to take just a couple of seconds now to see if we have a request for public comment. Seeing no requests, would you like to continue with the agenda?
Yes, please. Thank you, moderator. Before we move on to agenda item 2, I would like to pause for a few minutes to first and foremost recognize that this is Respiratory Care Week. And so we want to congratulate all of our licensees for the heroic work you do every day. And just know that we recognize you as you do the great work of taking care of our consumers. As someone who's under 40th year, I can tell you personally that becoming a respiratory therapist is one of the best decisions that I've ever made. I saw a meme this morning that says, "What does a respiratory therapist do?" And it says, stop breathing and I'll show you. With that, we move on to the next thing that I wanted to recognize. And so we're going to do something a little bit unorthodox. I would like to, Stephanie, if you could please come on camera.
I am present.
All right. We wanted to recognize that Stephanie is completing her 30th year with the Respiratory Care Board. And I would like to read a few of her highlights of her career in honor of this 30 years. And I'm sure this isn't everything, but it is hopefully something that you will appreciate the work that she's done for us. Stephanie was hired by the board in 1993 as an office tech. And through her own initiative, she climbed the ranks quickly, learning every board process and program. Stephanie began monitoring the board's budget in the late 1990s. She was responsible for tackling the runaway costs at the Office of the Attorney General. And she ultimately led to establish accountability by way of detail on regular monthly reports and a nearly 30% reduction in the AG budget line item. In 1996, Stephanie was recognized as a finalist for the Ray Ramirez Award for her outstanding service, positive attitude, and as an exemplary role model to fellow employees. In 1998, she left the board to become a manager of the policy and communications team at the Bureau of Private Post-Secondary and Vocational Education. But in less than a year, the former executive officer of the Respiratory Care Board lured her back to the board, establishing its first manager position for a newly created probation program. Stephanie established and staffed the program for 2 years prior to being appointed as the board's executive officer. In September of 2000, Stephanie and the board's probation program were the recipient of the Council on Licensure, Enforcement, and Regulations Outstanding Program Award. Stephanie continued her education while working full-time. She completed management certification programs through Sac State and UC Davis. She also obtained her degree in business administration in 2009. In March 2001, Stephanie was appointed as the board's executive officer to manage and lead 16 to 24 staff and administer budgets of up to $4 million. One of the first issues Stephanie addressed was the historically adverse relationship between the CSRC and the board. She was responsible for establishing a new working relationship with the CSRC, where both partners have since worked together to further share goals of consumer protection. Through 2004, 2006, at the board's request, she led in the research and outreach of reviewing the practice of respiratory care as it related to hyperbaric chambers, pulmonary function testing, and polysomnography. It was Stephanie's work that resulted in a bill to require sleep technicians becoming registered under the Medical Board of California to perform the respiratory care services associated with sleep studies. In 2009, the department tapped Stephanie to be the liaison for 19 healing arts boards to identify barriers preventing timely investigations of enforcement cases. She became the initial legislative author for the Consumer Protection Enforcement Initiative, sponsored by the DCA. The CPEI continues to be used by the Sunset Review legislative staff and has been used to amend laws to re-engineer processes to reduce enforcement processing times from 36 months to between 12 and 18 months. In February 2010, the Department of Consumer Affairs and the Governor's Office honored Stephanie for her integral role in the development of the CPEI and her yielding dedication to consumer protection. In 2011, Stephanie was recognized by the DCA for her role in developing uniform standards, specifically for chairing the subcommittee concerning drug testing frequency for substance abuse licensees and for being the driving force in achieving middle ground with the affected groups. Stephanie has continued to bring the board forward in technology, from establishing the board's website and online license verification in the early 2000s to currently what is almost a fully paperless operation. She was also the first board to post disciplinary actions taken back in the early 2000s. She was the architect of the Breezy platforms that launched in 2013. She spent countless hours mapping and diagramming the layout. She also went to serve as one of the members of the Change Control Board for Breezy for several years. In 2020, Stephanie was on call 24/7 when the COVID pandemic affected all state agencies. She was instrumental in responding to concerns of workforce shortages while at the same time managing and establishing guidelines for staff operations from home. Through her entire time with the board, Stephanie has emphasized with staff the importance of providing excellent customer service. She has rejected the implementation of telephone trees, and I believe you will be hard-pressed to find any other state agency that you can call, speak to a live person, and have your issue addressed immediately. Since 2001, Stephanie has successfully led the board through 4 legislative sunset reviews, and more recently received accolades from legislative staff for having one of the best functioning boards under the department. Since her tenure, Stephanie has researched and implemented numerous laws and regulations aimed at increasing consumer protection, reengineering processes, reducing expenses, and align change with changes made by outside entities. You were supposed to be in your office, so Christine has a plaque that she wants to show you. It will be waiting for you when you return. Christine?
Wow. I think I'm shaking a little bit. I'm so uncomfortable with this. Thank
Hopefully
you
you're
so
getting,
much.
it's very hard to get the effect, but this will be waiting for you.
Thank
All
you.
right, thanks, Christine. And thank you, Christine, for researching this information for me.
You're very welcome.
So
It's a nice walk down memory lane.
Yes.
I was wondering how that was a lot of information. Thank you so very much. I appreciate that so much. I just have to say thank you to the board members. I've had such wonderful board members over all these years. The best. I'm not just saying that. I hear from other boards. I really have been very fortunate. And my staff, I can't tell you that none of this would be possible without them. I have the best staff, no doubt. And I appreciate every single one of them. Thank you so much.
You're welcome. Well, we know that we, as a board, we honor you, and we are grateful to be able to do this with you.
Thank you, President Desmond.
Of course. Okay, now we can move on to agenda item number 2. This is the approval of the June 22, 2023 meeting minutes approval. It is attached to our agendas. Are there any additions or corrections from the members?
I move to approve.
Second.
Real quick, this is Reza, Board Counsel. Since we're in a remote setting, can whoever makes a motion and makes a second, identify yourself so whoever's taking minutes can log that. That would be very helpful, I'm sure.
Hi, this is Mark. I made the motion to approve.
And it's Dr. Mehta. I seconded it.
Thank you very much.
Moderator, do we have any public comments?
We have a motion and a second on the floor. If you'd like to make a comment on the meeting minutes, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users will need to dial *3 to raise a hand, and we will call on people in the order we have requests. We're going to take just a few seconds now to see if we have a request for public comment. Seeing no request for public comment, do you wish to continue with the motion?
Yes, please. Thank you. Katie, would you please perform the roll call vote?
Mary Ellen Early,
Aye.
Ray Hernandez,
Aye.
Dr. Mehta,
Aye.
Sam Kabushian,
Aye.
Michael Terry,
Aye.
Sarah Williams,
Aye.
Vice President Goldstein,
Aye.
and President Guzman.
Aye. Thank you, Katie. The motion passes. I will now turn it over to Stephanie to update us on the implementation of our recently approved CE regulations.
Thank you, President Guzman. Hello, everybody, and happy Respiratory Care Week. We are doing the CE Continuing Education Update. I'm just going to review what we've done so far. As you know, the regulations were approved by the Office of Administrative Law in August 2023. Highlights of the changes include the number of CE hours required to be completed remains at 30 hours. However, instead of 20 hours required for directly related respiratory courses and up to 10 hours indirectly related courses, the new framework is 15 hours directly related to the practice, 10 hours directly related to respiratory care leadership, and up to 5 hours indirectly related to the practice. 15 of the 30 hours must be from a live interactive course. Such courses may be delivered in person or through the internet. Attendance at certain meetings may now be counted for up to 5 hours CE credit. The new leadership category includes completion of already required law and professional ethics course and a brand new section to recognize qualified preceptor training and preceptorship for CE credit. Additional credentialing exams and certifications are now recognized for CE credit towards direct care. The regulations were legally took effect October 1st, 2023. We decided to begin implementation January 1st, 2024. It's going to be a 2-year implementation, so it will take until December 31st, 2025 to be completely implemented. We created a CE webpage that became active on September 19th. We sent an e-blast and a newsletter to all licensees on September 29th. And then we started our monthly emails that we'll be sending to each group of people who renew each month. The first one was for our December 31st, 2023 licensees. They were issued an email separately. And inside each renewal application will be a pamphlet that explains the highlights of the new requirements, and that pamphlet's also on our website. So since we sent the big e-blast out on September 29th, the feedback that we got, initially we got several calls. We estimate we've had about 50 calls, which is really not that many considering the number of licensees we have, somewhere around 23,000 active licensees. So we sent the initial notice out on September 29th. And the inquiries that we did receive were in 3 different areas. There was a misunderstanding of leadership courses. A lot of people felt that meant management courses, and once explained that it did not necessarily mean management courses, just more, I think, independent critical thinking kind of courses. They seemed to understand. And then there was a misunderstanding still with the live requirement. But once they understood you could do it online, their concerns were also alleviated. We did have a few CE providers comment that they're modifying their courses to meet both leadership and live course requirements, which is a great indication that the industry is adapting and taking advantage of the new opportunities that these regulations bring. And we also had one caller who expressed her excitement that we are recognizing preceptors for continuing education. And that's my report. Does anybody have any questions or comments? I will send it back to you, Ricardo, for public comment.
Moderator, do we have any public comments?
We are accepting public comment on the update. If you'd like to make a comment, please raise a hand by tapping that hand button at the lower part of your screen. Dial-in users, please dial *3 to raise a hand. And Irene, I see you wrote a comment. We're going to give you an opportunity to speak that. We're going to start with Craig. Craig, I'm sending you a request to unmute your microphone. You'll be given 3 minutes to speak with a 30-second warning. All right, Craig, I see you're unmuted. Go ahead, please.
Yes, hi. Well, first of all, I do want to comment. My name is Craig Gregorio, and I work at the ceplace.com. So we've been providing CEUs for RTs in California for over a decade. I will say a few things, and I know I only have 3 minutes, so I'll say it quickly. Christine was wonderful. I got a chance to talk to her. She was amazing. So I concur with all the great customer service you guys provide. I had a few concerns with the new regulations. One is the comments that were made and stated that this is not impacting any small minority business owner. And I just want to be clear that that couldn't be farther from the truth. I completely have to pivot in order to even stay in business. And, you know, I don't want to bother everyone's time with what I have to do to make that happen. But if I were to stay as is, I would be out of business. So, and I am going to try to pivot to align. So I do want you guys to know that there are other minority business owners that this has impacted that I've had a chance to talk to as well. But the two concerns that I have do relate to the two things that were highlighted. And one is the management leadership courses, because a lot of research does indicate that regardless of industry, only 38% of individual contributors aspire to go into leadership roles. And what that means for RTs specifically is that 62% are basically removing that clinical education that they would be getting otherwise and moving it over to management-related, leadership-related courses. And so the concern I have is that because it's not optional, because I agree with the objective in terms of increasing preceptors, management in RTs and all that, by making it, mandating it and not optional, what you're essentially doing is you're removing the clinical knowledge for some of your RTs, 62%, roughly speaking, because they're not going to go in that direction. And that's really not a desire of theirs. And I realize that you're not just speaking of managers per se, you're talking about leadership type courses, but really in doing that, the clinical education that they could be taking for those 10 CUs are now being redirected to an area that isn't as interesting to those 62%. So the concern is instead of optional, mandating. And then the second piece, of course, is the live courses, because any educator knows there's different learning styles. You have visual, audio, read, write, kinesthetic, and depending on the learning style, everyone has a predominant learning style. So when you move and shift half of your CEUs to audio, you're basically excluding those who have predominant styles, learning styles of read, write, visual to some extent. And so the concern is that now the knowledge transfer isn't going to be absorbed at the same rate it would have been.
30 seconds.
Otherwise. And so both of those seem like they should be optional, not mandated. And as a result, I think some of the objectives that you have may not, you may not see the results that you were hoping for. So again, I appreciate the goals and objectives. I think those are logical and rational for the state. The concern I have, though, is that by making these mandated, you're pushing away from some of your objectives, the goals. Philadelphia, for example, went the opposite direction of that California just did. They tried this before, it didn't work, so they've reverted back to having all learning styles available. Thank you.
Thank you, Craig, for your comments.
All right, next we have Irene. Hold on just a second, Irene. We're going to give you an opportunity to unmute your microphone.
Can you hear me?
Yes, go ahead, please.
Oh, okay. My concern is my question is how many hours will be credited for like the BLS, ACLS, PALS, and the ethics? That was my concern. And then the other thing is that I know you want us to go to some of these, seminars and stuff, but at the same time, some of these seminars are at other states. So then we have to think about, how we're going to get there, the airfares, the hotels, that really costs. And then at the same time, they're charging for the classes. So that's another issue. I mean, I understand that you want us to participate, as far as being there, and grasp it. But like the other gentleman says, I'm really a visualer. You know, I'm more of a visualer and listening. But my concern is, you know, it's going to cost if we go to other states to go to these classes. I mean, that's my concern. Thank you.
Thank you, Irene, for your comments.
Next, we're going to hear from Carol Hanft. Hold on just a moment, Carol. We're sending you a request to unmute your microphone.
Hello?
Hi, go ahead, please.
Yeah, I have a comment. I think the last speaker had a very good comment that she made concerning the expense if we do go to in-person seminars, but I believe you said we might be able to access this through a video or online format, Zoom type of situation, I understand. And then I wanted to address the management or the, management and those types of courses. After hearing what you said in your opening remarks about them not being necessarily directed towards management, I kind of get it more. And what I think Craig was saying and potentially doesn't really understand is that at the bedside, when, as anyone who has worked at the bedside in a, acute care hospital, respiratory therapists are often the firemen of the hospital. They call us anytime a patient is having a trouble, and the nurses often look to us for directions. Sometimes even younger physicians will look to the respiratory therapist. I myself have been certified 40 years this November 12th. I have worked at many universities, neonatal, pediatric through adult intensive care units, and I think part of what these classes may be trying to teach us is how to be a little more, political and, just do it in a very smooth and easy way. Come in, help rescue the patient, but also do it in a style that unifies the working team with the patient rather than just brings up, sometimes RTs, including myself, have very large personalities. And I think that learning these types of classes is going to help me in my skills in working with my different care teams. So I don't really have a problem with the educational directions you're taking. And those are my comments. Thank you.
Thank you, Carol, for your comments.
Thank you. Next, we're going to hear from Sue. I believe the name is pronounced Sue. Correct me if I'm wrong. We're sending you a request to unmute your microphone.
Can you hear me?
Yes, go ahead, please.
So if you could speak to the preceptor CEUs. For example, I'm certified through my hospital as a preceptor. But the hours that you have it broken up into, you're saying 5 CE hours for 500 to 999 hours of preceptor supervision, 10 CEUs for 1,000 to 1,499, and 15 CEUs for 1,500 or more hours. I'm bedside RT and at an acute care hospital. So, right, 3 12 hours a week if I'm working that every single week. And correct me if I'm wrong, but is around like greater than 1,700 hours a year. So to get any CEUs for my preceptor work, I have to be doing a majority of those hours as a preceptor. And that's not even possible considering the number of hours that we have students and new hires in our facility. So I'm not really understanding that part of it. I love that you're trying to add in CEUs for preceptors, but the hours compared to a bedside therapist's work and the availability of preceptor hours, it doesn't add up. I think that so then it leads me to believe that you're guiding that to a very small minority of RTs, which would be RT instructors who work full-time for a school. And that's a very small number of RTs. Also, just to make a comment again about the live courses, I think that remains to be seen how many online live courses we have available. And if you could speak to, do we actually have to be live the moment that they're happening, or can we be participating in them on a recorded basis, right? Like some of these live courses, you're allowed to take them later on after the date that they're given. Does that still count as live hours? Because I'm also on the Central Coast, which we're kind of in a bubble. So we don't have a lot of opportunity to go to live courses without doing hotel rooms and travel and whatnot.
30 seconds.
So that's it. Thank you.
Thank you, Sue, for your comments.
And those are all of our requests for public comment at the moment. Do you wish to continue with the agenda?
Yes, please. Thank you. I just would like to comment or address a couple of comments. First and foremost, thank you all of you who showed up today to engage with the board. We appreciate your engagement and your hearing from you. It is important that we hear from you. I do want to make a comment about this issue with the live courses. And Stephanie, you can step in if I say anything that's not correct. But it is, as I stated before, as it has been stated before, it's not just attending a course in person, but it's also courses that are provided via the computer that are live. As long as they're live, it doesn't have to be in person. And so, for example, this Friday, UCSF is having their fall one-day seminar that is being available both in person and in Zoom. And so that would apply. I will say, I have, I'm a practicing respiratory therapist, and I have not done an online CEU in about 10 years. And I have not left the state to do so. So that I want to make sure I address that. We're not forcing anyone to leave the state. I'm assuming someone will be referring to the ARC Congress that is out of state. We have a state conference every year that provides for 15 CEUs, and a Tahoe conference once a year that provides 15 CEUs. And so it's they're both, yes, they do both require personal attendance, but definitely it can be achieved. The other thing I wanted to address, there was one comment about the hours. Just want to make sure I clarify that clinical instructors from programs, RT programs, are not eligible for those hours as part of their employment to visit students and precept them. That does not qualify. This is only for preceptors at the bedside and not for programs. Having said that, let's see.
I just want to add one thing. I encourage anybody who has any questions about the CE requirements to go to our website. It's laid out really well, and it should answer any concerns or questions you have. And if you still have questions, please contact our office.
Thank you, Stephanie. All right, next up on our agenda is financial analysis review. And so I'm going to turn it over to Christine for her report.
Hi. Attachment 4 in your agenda materials is the current financial analysis and review based on final expenditure and revenues for the fiscal year that ended on June the 30th. As reflected, the board's fund is projected to remain solid in the coming years. That's always great to see. A new bargaining unit contract was recently approved and calls for 9 to 10% salary increase over the next 3 fiscal years. This will also be retroactive to July 1 of this year. As we previously shared, salary increases not only result in increases to our own salary and benefits budget, but also to increases in areas such as pro rata. the amount that we as a board pay to DCA and the state for providing administrative services. This is something we are watching closely as we move forward to determine what fiscal impact this will have on those costs. I also wanted to point out that we do continue to closely monitor application numbers, which have shown a gradual increase in monthly license which have showed a gradual increase. And we also monitor monthly license statuses, which have remained steady. I also wanted to highlight the one-time $139,000 transfer to the general fund that was required by AB 84, a budget trailer bill back from the legislative year 2000-2001, I believe, which required state departments to reimburse the general fund for their share of $2.5 billion used to lower state employer retirement contributions to generate savings to mitigate a recession caused by COVID. DCA's overall share of the $2.5 billion was $21.8 million, and the board's allocated share was the $139,000 you see reflected on the fund condition. And other than that, unless anyone has any specific questions, that pretty much sums it up.
Members, do you have any questions? Seeing none. Moderator, do we have any public comments on this item?
We are open for public comment on agenda item 4. If you'd like to make a comment, please tap that hand button at the bottom of your screen to raise a hand. Dial-in users will need to dial *3 to raise a hand, and we will call on people in the order we have requests. People will be given 3 minutes to speak with a 30-second warning. And our first request comes from Carol. Hold on just a moment. We're sending you a request to unmute your microphone.
Hello?
Yes, go ahead, please.
Yeah, my understanding is that this is not the first money grab that happened from our account by the state. Am I correct in that? Didn't this happen sometime, I want to say maybe the 90s or the 80s? I've been doing this almost 40 years, and I remember that. Did they return that money? I was just curious. And also, is it possible to get a link to that USC class on Friday? Because that sounds great. Thank you.
Thank you,
Well,
Carol.
I can speak to, you are correct. There was, if I remember the number correctly, about $785,000 that was taken as a general fund loan back in the 90s, but that was subsequently, there was actually a lawsuit, and it was determined that those types of loans were not, I guess, kosher, if you will. And so we did receive that repayment from the general fund. This is a little different because it wasn't a loan. It was something that was included as part of legislation in a budget trailer bill. So, I mean, to put it simply, this was not something that we had an option to try to keep from happening, really.
Thank you, Christine. And the link for that seminar, Carol, is if you go to UCSF conference, type novelties in respiratory care, you'll be able to see the link there. If you have any questions, you can email ramona.burke, B-U-R-K-E, at ucsf.edu. And hope to see you there. All right. Moving on to item 5. I'm going to turn it over to Stephanie to present the licensing and enforcement activity annual report.
Okay, so you do have an attachment in your agenda packets and available online. We publish this every year. We bring it to the board so you have a look at what we are doing. We have a slight uptick in complaints and investigations, but staff continue to meet our timeline goals for processing complaints, investigations, and prosecutions. The goal to process a case from the date a complaint is received through investigation and final adjudication through the Office of the Attorney General is 540 days, and we are currently at an average of 465 days. I don't have a whole lot else to point out on this report, but if you have any questions and have taken a look at this, please let me know.
Members, any comments or questions?
Yes, President Guzman, Ray Hernandez here. Just wanting to acknowledge just in the report itself, there's been conversation just about our workforce pipeline, and I'm happy to see that we're up almost 500 active licensed from last year, and just to make note of that, please.
Thank you, Ray. Any other comments from the board members?
Hi, yeah, this is Dr. Mehta. I had a quick question. I just see the increase in number of complaints received, and I was just wondering, like, when these complaints initially come to our table, is there any questioning that we do in terms of was there any any other process that was followed to discipline the person that was complained against within their system, or do we just take up every complaint and go forward with it?
Well, that's a very big question. When we get a complaint, we're going to look at it and determine if it's relevant. And there are many different ways you can discipline it. We use citation and fine, and we make sure that we don't abuse that. The fine amounts are depends on the violation, but if probation's not going to be like a good form of discipline because of whatever the violation is, maybe it was just a flat out error, a DUI, one DUI, not several. We may find somebody because that allows us to tell them this is not okay for your license, but it also makes it a public record, and it also allows us, so if they get a second one, then that might be an indicator that there is a substance abuse problem. And then that would be something we would go forward with probation. So there's citation and fine. There's also just education letters that don't have any fine attached to it, just to let them know. There's also, if it's a heinous act, we'll go to the district attorney and also pursue criminal charges. And then in addition to probation, then you could have suspension or revocation. But as far as when we get a complaint, it depends on what it is and how we move forward.
Oh, just something else I wanted to add was, do all of these complaints automatically get, when you said, we issue fines, does it still involve a full-fledged legal process, or is that something that we can turn around just within our own purview?
No, it still allows them to appeal the citation through the legal process.
So every complaint goes through a legal process. There's nothing that we can turn around with just.
The only thing that we can do is I think we can just issue the education advisories, or I forget what we're calling them, strong warning letters, because there's no ramifications for that. That's just something that stays in-house. Mm-hmm. So that's the only thing that we can do without a legal process.
And is there have we done any of those strong warning letters with any of the complaints that we received?
Yes.
Okay. All right, because I
also wanted to add, with bringing up investigations that are done by facilities, when there is a mandatory reporting complaint that is received because someone has been terminated or suspended for specific causes, we receive those, and we do reach out to the facility and in many instances obtain a subpoena the investigation, because many times some of the work has already been done, if you will, and we can utilize that. So we do work in those types of complaints. We do work hand in hand with the facilities that have reported.
Okay. All right. Thank you both. Thank you so much.
Thank you, Dr. Mehta. Any other comments from members? Okay, seeing none. Moderator, any public comments?
We are taking public comment on agenda item 5. If you'd like to make a comment, please tap that hand button at the bottom of the screen. And dial-in users will need to dial *3 in order to raise a hand. and we will take comments in the order they are received. We're going to spend just a couple of seconds now to see if we have a request for public comment. Seeing no request for agenda item 5, would you like to continue with the agenda?
Yes,
Mr.
thank
Board
you.
President?
Thank you, yes. Okay, Stephanie, can you also present item 6, the additional proposed legislation as it relates to SB 1436?
Absolutely. Okay, so last year, SB 1436 was signed by the governor. It allowed the board to codify and name basic respiratory tasks in an effort to reduce the unlicensed and unauthorized practice of respiratory care. In that bill, it laid out an exemption for home health agencies licensed by the California Department of Public Health to use trained LVNs to provide respiratory care to patients in the home, as it is unfeasible to require an RCP to provide that care for one patient. In October of 2022, right after the bill was signed, the board approved language identifying basic respiratory tasks in regulation, and staff publicly noticed the proposed regulations. By December, we had numerous comments that were received in opposition. While it remains the board's position that unauthorized persons practicing respiratory care beyond these basic tasks is illegal and has a myriad of liability issues, the perception to these facilities is that the regulations were the catalyst to making the unauthorized practice of respiratory care illegal. At our last meeting, the board agreed to withdraw the proposed regulations that laid out basic respiratory care tasks. LVNs are authorized to perform, to have time to make an attempt to provide an additional legislative attempt for exemptions for LVNs, trained LVNs to practice respiratory care beyond basic tasks in certain home and community-based settings. However, while we will attempt to secure an author and support from home and community-based stakeholders, it is important to note that next year, whether any legislative bill fails or succeeds, the board must pursue the regulations to identify the basic tasks LVNs may perform. So today, after much research, I am presenting a background paper. It's in your attachments, item 6, and proposed legislation as a means to secure an exemption for some of the home and community-based organizations to allow the practice of respiratory care by trained LVNs to prevent the reinstitutionalization of patients who prioritize their choice of their patient setting over the expertise of their healthcare provider. The legislative proposal provides exemptions in the spirit of the exemption provided to home health agencies in SB 1436 last year with the following 3 qualifiers. Facilities and homes that have a small home-like setting with 6 beds or less, with 1 or so few respiratory care patients, it makes it unfeasible to hire an RCP to provide all the respiratory care. Number 2, facilities and homes that are not currently using RCPs or RNs to deliver respiratory care. And number 3, facilities that are not explicitly required to use RCPs to deliver respiratory care. So right now, I'd like to direct your attention to page 15 of the attachment for agenda item 6 so that I may read verbatim, this could be difficult today, read verbatim the proposed legislation that the board is considering today. I want to do that to make sure that everyone has had a chance to look at this. So in this section, this is the place where we list all our exemptions. So this starts off with, this act does not prohibit any of the following activities. And I'm going to jump down now to page 15, letter J. The performance by a vocational nurse licensed by the Board of Vocational Nursing and Psychiatric Technicians of the state of California who meets the additional qualifications under paragraph 1 of this subdivision to perform respiratory care services identified by the board and within the scope of patient-specific training and the certifications required under paragraph 1 of this subdivision while practicing in settings listed under paragraph 2 of this subdivision. Subdivision 1, in order to perform respiratory care services in accordance with subdivision J of this section on or after January 1st, 2028, the licensed vocational nurse shall have completed patient-specific training satisfactory to the employer and shall maintain current and valid certifications of competency for respiratory tasks performed from the California Association of Medical Product Suppliers or California Society for Respiratory Care or another organization identified by the board. Subdivision 2, licensed vocational nurses may perform respiratory care services pursuant to this subdivision exclusively in the following settings. A, at congregate living health facilities licensed by the California Department of Public Health that are designated as 6 beds or less. B, at intermediate care facilities licensed by the California Department of Public Health that are designated as 6 beds or less. C, at adult day healthcare facilities licensed by the California Department of Public Health. D, as an employee of a home health agency licensed by the California Department of Public Health. E, at pediatric day health and respite care facilities licensed by the California Department of Public Health. F, at small family homes licensed by the Department of Social Services designated as 6 beds or less. G, as a private duty nurse as part of daily transportation and activities outside of patients' residence or family respite for home and community-based patients. With that, since the distribution of the agenda materials, I did receive some feedback that I had not included independent nurse providers in residential homes, and this was an oversight on my part. So with that said, I am recommending that we have one change to this, and that would be subdivision J2D currently reads as an employee of a health home agency licensed by the California Department of Public Health. And it should be amended to read as an employee of a home health agency licensed by the California Department of Public Health or an individual nurse provider working in a residential home. To begin discussion, I would recommend the following motion if a board member so chooses to make. I motion to approve this legislative proposal as presented, including the amendment by the executive officer, and direct staff to work with our executive committee to secure an author and make amendments as appropriate and in line with this proposal. If any substantive amendments are made to the language, members shall be notified prior to the next scheduled meeting. In addition, this matter shall be on the next agenda for updates and discussion as appropriate. And with that, I will turn it back over to President Guzman to see if we have a motion to move forward with this legislation and begin discussion.
Thank you, Stephanie. Can we get a motion?
I'll make
A second.
Motion.
Open it for discussion.
Make a motion.
I second it. The smart.
Okay.
Sorry, who made the
Sam
motion?
Kabushian, I made the motion.
Thank you.
Members, any questions or comments?
Do we know who seconded it?
It was Mark. Okay, seeing no questions from the members. Moderator, please, can you open it up to the public for comment?
Absolutely. We are now taking public comment on agenda item 6, SB 1436. If you'd like to make a comment, please tap that hand button at the bottom of your screen. Dial-in users will need to dial *3 to raise a hand, and we will call on people in the order we have requests. And our first request comes from Jennifer. You'll be given 3 minutes to speak with a 30-second warning. Hold on just a moment, sending you a request to unmute your microphone. Think I heard you, Jennifer.
Okay, awesome. My name is Jennifer McClelland. I'm a parent of a 12-year-old child who is tracheostomy and ventilator dependent. My son spent most of the first year of his life in institutional care in a pediatric subacute facility more than 200 miles from our home. I know what kind of care institutions deliver. That's why I'm so passionate about the systems that make it possible for tracheostomy and ventilator dependent kids to live at home with their families where they belong. Home care in California is messy. It's chronically underfunded and families struggle to get any help at all. Home care isn't just care at home, it's care that makes it possible for disabled people to live normal lives. I'm grateful that the RCB is working out a home care exemption so that LVNs can continue to provide respiratory care services they have historically provided, but with better and more standardized training. I want to make sure that a specific group of LVNs are included in the home care exemptions, individual nurse providers, AKA INPs. INPs do exactly the same work as home agency nurses. They just work through a special state program that allows them to bill directly for services. INPs are LVNs who specialize in home care for medically fragile kids. Many work through the foster care system or in rural areas where home nursing agencies don't exist because they can't make a profit. Home nursing agencies pay LVNs a small fraction of what they get paid by the state in order to make a profit. By working as INPs, LVNs can make a living wage, which means they can stay with the same family long term. That's a big help for our kids. I've been in communication with Stephanie Nunez about this issue, and it has been awesome to work with her. She's assured me that there wasn't an intent to include the INPs and that we just need to tweak the phrasing. It's been really great to work with her about all these complicated acronyms that are considered home and community-based settings under CMS rules. I agree that section of BP 3765 should add a phrase to include LVNs working as INPs so that INPs can continue providing care and participate in the education and training when it's finalized. I'm also grateful for the changes that ensure that LVNs working in school settings will be included in the exemption, and also for the inclusion of PDHCs, CLHFs, IHFs, ICFs, and all the other home and community-based alphabet soup settings. Home care isn't just the care that home nursing agencies provide in homes. It's care that makes it possible for disabled kids and adults to go to school, work, and interact with the world. I'm grateful to the RCB for working
30 seconds.
Improve the care that disabled kids get at home. If these exemptions don't get codified into law, kids who are currently living at home will lose access to care. Families will either have to institutionalize their children or, more likely, figure out how to keep kids at home with no help at all. Home care can barely staff LVNs. There's no way we can staff these cases with RNs, and there's no billing structure that makes it possible to staff these cases with RTs. I'm very grateful for everyone's time, and I'm thankful that someone at the state is paying attention to the quality of care these kids get at home. Thank you.
Perfect timing.
Thank you, Jennifer, for your comments.
Thanks.
Next, we're going to hear from Denise, followed by caller 6. Hold on, Denise. We're sending you a request to unmute your microphone.
My name is Denise Ordonez. I'm from Aviana Healthcare, and first and foremost, we appreciate that the RCB is excluding home health agencies and recognizes the importance of the services that we provide to our patients, so we definitely appreciate that. Stephanie, I just wanted to get some clarification with regards to subdivision 1, specifically the requirement for maintaining current and valid certifications of competencies with either the California Association of Medical Product Suppliers or the California Society for Respiratory Care or another organization identified by the board. So will that include any home health agencies and whatever current program that they have, or do our LVNs have to go through either one of those avenues?
Actually, the home health agencies will have an additional option because of the legislation that was passed last year. So you still have that option. This is just an additional option for you.
Perfect. Thank you so much for that clarification.
Welcome. And Ms. McClellan, thank you so much. I just have to comment for the record, she has been fabulous and has helped me tremendously break this down. Thank you, Jenny.
Thank you, Denise, for your comments.
All right. Thank you, everyone. Next, we're going to hear from caller 6. You will need to dial *6 in order to unmute. Give me just a moment. We're going to send you a request to unmute your microphone. All right, caller 6. I see you've unmuted.
Hello. Hi. Can you hear me?
Go ahead, please.
My name is Heidi Gibson. I've been at LVN since 1999. Since about 2013, I've been caring for medically fragile foster kids in my home. This is a wonderful program because children get to be in a home with a family versus staying in an institute. They live with one main caregiving family and they become part of our family. I've cared for several children, but 4 have had trachs and vents. I've used INP nurses to help in our home as these kids are truly 24-hour care. I have seen babies needing ventilators 24 hours a day, go to being able to sprint for large portions of the day. My own son, whom I adopted, came off the vent at 3 years old, despite being told he would most likely require it forever. I know that LVNs can use more training in vent and trach care, but for myself and the INPs I have used, as well as the foster parents, INPs that I know, we have really seen some great progress in these children. And I just want to make sure that INPs are included in the home care exemption so that INPs can continue to provide the quality care they're currently providing and have access to the training program when it is finalized.
Thank you for your comments.
Thank you.
All right. Next, we're going to hear from Catherine. Hold on just a moment. We're going to send you a request to unmute your microphone.
This is Catherine Severson. I'm a nurse consultant working with the ICF homes, and I work for California Department of Developmental Services. And I wanted to say thank you very much for looking at all of the homes, the types of settings where our clients live. And I certainly echo Ms. McClellan's comments, as well as the previous speaker's comments. I do have a couple of questions regarding the exemptions on page 15, Ms. Nunez. Looking at the supporting documentation there, I also see on page 16, down at the bottom, there are exemption qualifiers. And I was not clear if a home needed to meet all of those, or a setting, a residential setting, either an ICF or one of the other types of settings that you've mentioned. So if a home needs to meet all of those, or if they only need to, I guess I'm unclear about the exemptions and how they would work going forward. And I realize you may not be answering this at this point in time. And then I also had a question about 2B, the intermediate care facilities licensed by CDPH. Is that intended to include all of the different ICF facilities, as there are several different license levels? I'm curious about that. And back to the exemption qualifiers on page 16, do those qualifiers only apply to the facilities listed under the CDPH and DSS on page 16? So where do the homes, the adult residential facilities for people with special healthcare needs, or ARFPs, fall? And they're staffed by RNs, and they do have respiratory therapists available. So several questions. Thank you.
I would just respond. The 2B does include all the intermediate care facilities that are licensed as intermediate care facilities. I know you have several different kinds, but it does include all of them that have 6 beds or less. And then the qualifiers that you pointed to, those were just the criteria that was used to develop the exemptions. So what you see in the legislation is actually who's being exempted, but that was just the criteria, as I said, to determine that. Because the you had mentioned the AARCF, those are currently staffed by respiratory therapists and RNs. And I may not be getting the acronym correct. I'm trying to look for it right now. Those would not be exempt.
Okay. I know all the acronyms are very confusing.
Yeah, and if you would like to discuss it more, I'd be happy to talk with you. Send me an email, give my office a call. We'd be happy to connect with you and talk in more detail with you.
Yeah, you've been very helpful. And one last question, looking at the minutes from the June meeting, just want to make sure that my understanding is correct, that the RCB deciding what are basic respiratory tasks, that is going to be decided in the future. Is that correct?
Well, this is kind of a gray area.
Okay.
Right now, that is considered the basic task. The fact that we're going to do a regulation is simply codifying it. As of today, no LVN should be performing respiratory care beyond those tasks.
Okay.
So that's where I was saying it's creating a legal liability for some people right now who are doing that. But that's why we're coming in behind, trying to clean this up and make it very clear what is okay and what's not, and give the exemptions where we can.
Thank you, and I appreciate that. If I have additional questions, I will reach out to you. Thank you very much.
Great, thank you, Catherine.
Thank you, Catherine. Thank you, Stephanie.
And I have a quick interruption before we continue with the motion, Mr. Board President. Back in agenda item 4, there was a discussion about a link to UCSF. If someone would type a question in the Q&A box, just type UCSF link. I will post that link as a response to that question. And I believe we're ready to continue with the motion on agenda item 6.
Excellent. So Stephanie, we can move on with the motion as you stated it, correct?
Correct. The amendment that not everyone, several people noted concern with, the individual nurse provider, is the amendment that I added to the motion.
Okay.
Quick interruption. This is the moderator. We have a hand up, which I believe is a question for agenda item 6. Do we want to take an additional question?
Yes.
All right. Hold on, Jerry. We're going to send you a request to unmute your microphone. You may need to dial *6 in order to unmute.
Can you hear me?
Yes, go ahead, please.
Okay, yes. I just wanted to ask a question regarding the distinction that's being made between 6 or less beds versus a number greater than 6. For example, congregate living facilities may have 6 ventilator-dependent patients in there and not have a respiratory therapist, which is currently the situation that's existing. An 18-bed or 15-bed congregate facility, if it has less than 6 ventilator patients, would they be included in this exemption? And I guess the question is, why the distinction between less than 6 beds or less versus greater than 6 beds?
So if you go back to the qualifiers, it was done in the spirit of providing the home care exemption, where there was only one patient in the home and it being unfeasible for a respiratory therapist to be staffed there all day. I apologize. So it goes back to that. And then we come to, it is a 6-bed designation. It is not a 6-patient designation because facilities are licensed by their bed designation. So when you come to an 18-bed designation facility, you could have 1 RCP patient or you could have 18. And the whole point of the exemption was for so few people. Generally, an RCP may be staffed for one RCP to 4, 5, 6 patients, depending on the acuity level of the patients. But for purposes of enforcing this and to stay in line with the spirit of the exemption of one RCP patient, we went ahead and acknowledged the 6-bed designation. In addition to that, 70 or 80% of the congregate livings are 6 beds or less. So
right.
That's where that came from.
Is there, it seems that there's an implication that if they have greater than 6 beds, they could afford to hire an RT? Because I don't know if that's accurate.
No, it doesn't go into affordability. It goes into the needed care. So if you have more than 3 patients, let's say, and you're giving, you can employ a full-time respiratory therapist, then that is what you should be doing. Whereas it's unfeasible when you have 1 patient in home to employ a full-time RCP to give a couple of treatments throughout the day.
Okay, thank you.
Thank you, Jerry, for your comments. Thank you, Stephanie. So we have a motion on the table. Reza, can we move forward with the motion, or do we need to reread it?
Was the motion essentially to move as Stephanie had suggested earlier? Is that
correct?
I presume what it was. Then yeah, that motion would be ready to move forward, I think.
Okay, great. Thank you. Katie, would you please perform the roll call vote?
Mary Ellen Early,
Aye.
Ray Hernandez,
Aye.
Dr. Mehta,
Aye.
Sam Kavushian,
Aye.
Michael Terry,
Aye.
Sarah Williams,
Aye.
Vice President Goldstein,
Aye.
and President Guzman.
Aye. Motion passes. We're moving on to item 7. I'm going to turn it over to our Professional Qualifications Committee Chair, Ray Hernandez, for an update regarding the work on Strategic Plan Goals 2.3 and 2.4.
Thank you, President Guzman. Appreciate it. From our last meeting back in June, we presented the findings from our focus groups. And again, just as a reminder, we've been in 2 years, maybe a little over, in terms of gathering, exploring data, and having board sessions. And so we continue to do that in relation to the strategic plan goals 2.3 and 2.4. At the end of that discussion, we, along with my colleague, Michael Terry, we formulated some recommendations. We had some conversations with the board, received some feedback, and the board supported moving forward with those recommendations. And of course, the recommendations really are to continue to gather data and have study sessions with the board. And so we met and we prioritized 2 of those recommendations. And those 2 were, one, and the board already supported at the last meeting, was to advocate for more capacity for higher education for respiratory therapists. And as such, a letter was created, and I think that letter is on its way to all programs in the state of California, advocating for building capacity for higher education, in particular bachelor's degrees. So that has already moved forward. The second piece that we're doing is gathering more information. And at our last meeting, we heard from representatives of bargaining unit SEIU. They forwarded some letters that they had received from their constituents, and we did receive those. There were approximately 5 letters. Of those 5 letters, one was not in support of a bachelor's degree as a minimum licensure qualification. The others we're really just looking at one, in terms of the impact of the workforce, and then two, grandfathering in terms of meeting current licensed practitioners. Would they have to meet any future requirements? And so we continue to state that any changes would apply to future licensees, not current licensees. So we have taken that feedback and certainly reviewed those. So thank you from SEIU for doing that. And so along with that, again, we know that it's important to gather more information. So our next step is we are currently in the process of creating a survey, and that survey would be aligned with the data that has been acquired and shared with the board in study sessions thus far, along with the focus group questions. So we're aligning that survey to include that information, and we'll be developing that survey. And the intention is, once that survey is ready, then practitioners across the state would be alerted. That survey would also be linked to the Respiratory Care Board website so that any stakeholder could participate in that survey. And so our hope is that we would do all that work, that we would conduct the survey, that we might analyze that data and present it at the next board meeting. If not the next board meeting, the following board meeting. And I'll pause there, Michael, Terry, to see if you have any other information that you'd like to add along with that summary.
No, I would like at the next board meeting to perhaps have the board actually take the survey, and so we can get survey feedback from them before we bring it to the general population.
Thank you, Michael. Appreciate that. And with that said, that's the at least update on the work that we've been doing in terms of the exploration for licensure requirements.
Excellent. Any questions or comments from the members? Seeing none, moderator, any public comments on this item?
We are now open for public comment on agenda item 7. If you'd like to make a comment, please raise that hand by tapping the hand button at the bottom of the screen. Dial-in users will need to dial *3 to raise a hand, and we will call on people in the order we have requests. We're going to take just a few seconds now to see if we have a request for public comment. And our first request comes from Denise. Hold on, Denise. We're sending you a request to unmute your microphone.
Behalf of SEIU United Healthcare Workers, representing 100,000 healthcare workers, including respiratory therapists across California. Wanted to again thank you, to the chair, to the board, for your continued partnership, and want to continue to be partners on this conversation, and appreciate you're looking into the survey to continue to keep us as a part of that conversation. So thank you.
Thank you, Denise.
And that was our only request for comment. Do you wish to continue with the agenda?
Yes, please. Thank you. Very well. Thank you, Ray and Michael, for that information and that update, and for your continuous work in this matter. I appreciate the work that you're doing. We just come to moving on to item 8, legislations of interest.
Ricardo?
Yes.
I see just in 7A, there's a CSRC legislative proposal for the advanced practice respiratory therapist. I don't know if that is a part of the agenda item.
Actually, yeah, I'd asked CSRC to update us on their proposal that they're developing for this, and Crystal Paddock has agreed to give us an update on that.
Oh, excellent.
Crystal, could you put your hand up on the thing so we can get you unmuted? Thank you.
Moderator, if you could please provide access to Crystal.
Crystal is now able to unmute at will.
Awesome.
Okay, thank you. So on August 15th, CSRC met with members of California legislation, including members of the Health Committee, to introduce what an APRT was. We've done this early on just to kind of get some feedback from legislation to tell us where we should go when we are going to be proposing for licensure for a professional, for an advanced practice respiratory therapist. We got a lot of great feedback from them. And so currently the CSRC is working in both our GA committee, our Government Affairs Committee, and our Professional Advancement Committee to come together to work on a proposal for legislation for APRT licensure in California. This is going to be a long project, but we are gathering information currently, looking at data specifically for our Californians with chronic pulmonary diseases. We're looking at how many pulmonologists we have that are practicing within California and what areas. And we're trying to figure out what the need is prior to coming up with this proposal. We did have, for those of you who attended the last Respiratory Care Board meeting in June, Abdullah from Loma Linda presented his survey results that had details regarding APRT and the perception of APRT in California from respiratory care practitioners. He's also gathering more data from physicians, specifically pulmonologists, regarding what their perception is of APRT and the need. We also met with Bill Croft, who is the NCRCB president, who met with our GA committee, our Professional Advancement Committee, and Jennifer Tannehill, our legislator, or our, who works for Aaron Reed and Associates. She is our lobbyist, and gave us some feedback on where North Carolina is in passing the APRT in that state, to kind of help us with the information that we're going to need when proposing this. And lastly, the AARC has had a work group come together, and they are working on providing resources to various states who are looking at the proposal of APRT licensure. And so we look forward to hearing from them later next month. They should be getting some information out to all of the states and the CSRC so that we can see where to go next regarding APRT licensure. But we are looking at 2025 as proposing this legislative action. Any questions from the board for me?
Excellent. Thank you, Crystal. Any comments from the board?
I'd just like to say, this is Michael Terry, I'd like to say thank you, Crystal, for your efforts and the efforts of your groups in making this happen. And have you defined a scope of practice that you're proposing yet?
Not yet, but we've gotten a lot of feedback. So the NBRC and COARC have talked about the licensure or the credentialing for this and looking at programs and everything. It has to be a master's degree minimum in respiratory science. The scope of practice we are looking at is the one detail that we're really trying to piece out is the prescriptive rights of this practice, this practitioner. It is not for North Carolina. They have proposed prescriptive rights and have had to go back on that and are going forward with ordering rights. And we've learned a lot from our counterparts, nurse practitioners, PAs who've gone through the same process and started out with ordering rights versus prescriptive rights. So we're kind of working out these details currently.
Excellent. Any other questions or comments from the board members? Okay, seeing none, moderator, I'd like to give an opportunity to the public to comment on what Crystal has shared with us?
We are once again open for public comment on agenda item 7A. If you would like to make a comment, please raise a hand by tapping that hand button at the bottom of your screen. Dial-in users will need to dial *3 to raise a hand, and we will call on people in the order we have requests. We're going to take just a few seconds now to see if we have a request for public comment.
I meant to ask a question actually, but I think there might have been a delay in putting my hand up.
It's okay. Go ahead.
I know that Crystal mentioned prescriptive rights. What are some of the things that are being requested or considered under prescriptive rights? Is it procedures or medications?
Yes, so for prescriptive rights, it's really the medications that the patient would essentially leave a clinical space with. So currently, what is happening in North Carolina is that they've gone back on their prescriptive rights. So the APRT will not have prescriptive rights, but they will have ordering rights within a facility. For example, within a hospital, you can order medications, ventilator changes, different diagnostic procedures. But in the clinic setting, when the patient is leaving the clinic, they cannot leave with a prescription written by that APRT. It would need to be a physician. So the APRT could prepare the prescription, the physician would sign it, approving it, similar to what a physician's assistant currently does.
Thank you. Looks like we have a public comment as well.
Yes, we do. Our first comment is going to come from Bridget. Hold on just a moment. We're going to send you a request to unmute your microphone. You'll be given 3 minutes to speak with a 30-second warning.
If there's any way, or if you need anybody else on any of the committees, how would I go about getting that information to help join a committee to help with the APRT?
So Bridget, you could actually, if you go on the CSRC website, you can find my email address. You'll see my name is Chair of the Professional Advancement Committee, and you can email me directly, Crystal Craddock, my name, and then I will get back to you.
Thank you, Bridget.
And that was our only request.
Thank you, moderator. Thank you, Crystal, again, for that information, for being here to share with us.
Thank you.
And so now I think we're ready to move to item 8, our legislation of interest. We have just come to the closing of the first year of another 2-year legislative cycle. Christine is going to give us an update on the legislations that we have been following. Christine?
Yes, thank you. So with regard to the 2023 legislation of interest, you will note that there were only a few bills that made it through the legislative process, and many which may become active next year. So we will continue to keep an eye on those. And then I'd like to highlight just a few for you. The first being AB 996, which related to continuing education and conflict of interest policy. The bill would require entities within consumer affairs who are responsible for approving CE providers or courses to develop and maintain a conflict of interest policy that discourages the use of any CE course if the provider of the course has an economic interest in a commercial product or enterprise promoted by the course. Back when we first discussed this bill, I believe last March, the board took a watch position, but requested that a letter be sent to the author providing feedback expressing concerns. So we did send a letter in April of this year where we essentially indicated that the members felt that it sent an unfair message that a provider with a financial interest in a particular product is somehow less ethical. So far, the bill has been ordered to an inactive file, and it may be one of those that becomes a 2-year bill, so we will continue to monitor it. The next bill is with regard to the AB 1028, which the board took an opposed position on. This had to do with the reporting of crimes mandated reporters, healthcare professionals. And this bill, we did send a letter expressing our opposition, basically indicating that it would diminish the protection currently afforded some of California's most vulnerable patients. This bill was also held under submission kind of late in the session, but it may also become a 2-year bill, so we will continue to monitor that as well. Another bill that was actually approved by the governor has to do, and we took a watch position on, has to do with requiring a board to replace a licensee's name or gender on their license and on any board operated website upon request when the licensee's name or gender has been changed or upon the licensee's participation in a safe at home address confidentiality program, and make records of the licensee's enforcement actions exempt from public disclosure, barring just some certain requirements. And so we have already, basically we would have to post a statement and then direct the individual, the consumer, if you will, to contact our office. So again, it was approved by the governor, and DCA has already begun communicating with the boards and bureaus to implement the requirements imposed by the bill, while also continuing to provide information to consumers. And then finally, there was SB 544 that addressed the Bagley-Keene Open Meeting Act and the ability to continue the teleconference option. It again was approved by the governor, and commencing on January 1, there will now be essentially 3 meeting options for full board meetings. And they include the traditional single location option, the traditional teleconference option where we would have to publicly notice each location where there is a member. And then finally, a new teleconference option that would allow for the majority of members gathered at one publicly noticed and accessible location, and any members above the majority to participate remotely from a private, non-public site. So there are a few different options that are available. In looking at it, I think that we will probably, to the extent feasible, continue with traditional single location options, but it is nice to have the other options available in the event they are needed. So unless anyone has questions about any of the other bills, that concludes my report.
Excellent. Thank you, Christine. Do the members have any questions or comments? Okay, seeing none, moderator, do we have any public comments?
We are now taking public comment on agenda item 8. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dialing users, dial *3 to raise a hand. And we will call on people in the order we have requests. We're going to take just a few seconds to see if we have a request for public comment. Seeing no requests, do you want to continue with the agenda?
Yes, please. Thank you. Okay, moving on to agenda number 9, election of officers for 2024. We'll start with Vice President, and I would like to nominate Mark Goldstein for Vice President. Did you accept that, Mark?
At this time, I would like to pass.
Okay. Do we have?
Thank you for the nomination.
Thank you, Mark. Do we have any other nominations for Vice President?
This is Michael Terry. I would like to nominate Ray Hernandez as Vice President.
Thank you, Michael. Do you accept that, Ray?
Second that. I second that.
I do accept.
Excellent. Christine, would you please, let's see, moderator, any public comments at this time?
We are accepting public comments on the nomination. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users need to dial *3 to raise a hand, and we will call on people in the order we have requests.
While we wait, this is Reza, Council. I presume there were no other nominations that board members wanted to put forward. If so, I think now would be the time, but it sounded like that was the only one.
Were there any other nominations, members?
Thank you.
You're correct. Thank you, Reza. Moderator?
We have no request for public comment at the moment. Do you wish to continue with the motion?
Yes, please. Christine, would you please take a roll call vote? And will each member name, well, no, just we only have the one nominee, so you can go ahead and take a roll call vote for Ray Hernandez for Vice President for the 2024 calendar year.
Mary Ellen Early,
Aye.
Ray Hernandez,
Aye.
Dr. Mehta,
Aye.
Sam Kabushian,
Aye.
Michael Terry,
Aye.
Sarah Williams,
Aye.
Vice President Goldstein,
Aye.
and President Guzman.
Aye. Excellent. Congratulations, Ray. We're looking forward to you being serving as Vice President for the next calendar year. At this moment, we would like to accept any nominations for President.
This is Michael Terry. I'd like to nominate Ricardo as president again this year.
I second that.
Any other nominations for President? And seeing none, I accept. Thank you for that. Moderator, any public comments?
Absolutely, all open for public comment. Could I get clarification on who the second was?
Sam Kabushian.
Thank you very much. We are open for public comment. If you would like to make a comment on the nomination, please tap a hand button at the bottom of your screen. Dial-in users, please dial *3 to raise a hand, and we will call on people in the order we have requests. We're going to take just a few seconds to see if we have a request for public comment. Seeing no requests, do you wish to continue with the motion?
Yes, please. Thank you, moderator. Katie, please take a roll call vote for all those in favor of myself serving as president.
Mary Ellen Early,
Aye.
Ray Hernandez,
Aye.
Dr. Mehta,
Aye.
Sam Kabushian,
Aye.
Michael Terry,
Aye.
Sarah Williams,
Aye.
Vice President Goldstein,
Aye.
and President Guzman.
Aye. And thank you. I look forward to serving as president for the year 2024. And we are ready to then move on to item 10. Schedule of 2024 board meetings, dates, and logistics. Looking at the attachment for this item, there's a calendar with suggested dates that are circled in red. It looks like the staff has to have targeted March 21st for first meeting in 2024. This date aligns with the CSRC annual conference in Temecula, which they have moved from June to March. They have seen large turnout. We have seen large turnout participation at our board meetings. Is there a concern with this date? I will say that I have a conflict with this date, unfortunately. I have a family plans for me to be out of the state that week. I could probably do the meeting WebEx, but not in person on that week.
If the date is good with everyone else, then I say we try to work some kind of a WebEx participation.
And this is Reza, board counsel. Just a minor thing. I would have to look into your ability to participate from out of state. I think that came up at one point and a question was raised about it. So I wouldn't count on necessarily being able to do that, but something we can look into.
Okay.
Ricardo, are there any other dates that you would like to propose to the board?
I could do any other date. So I'm gonna be in Florida from March 15 to March 24th. So I can do the first week in March, or I can do the last week in March. Any day. But if the intent is to have the meeting at the conference, what other options do we have, Stephanie?
Well, I thought you could WebEx in, but it sounds like Reza has concerns with it being out of state while doing that. So he's going to have to do some research on that. So, I mean, I think we should probably stick to the 21st and hope that we can get you in by WebEx. And if not, you know, you can always watch it. So you're, you know, I guess it's not quite the same, but and go that route only because there are so many participants at the CSRC meeting.
Yes. So
is it the 21st or the 24th? I'm sorry.
21st.
Ooh.
March 21st.
I won't be able to make that one either.
Oh dear. Okay. Well, now we're looking at a different date.
And just to be clear, this is Reza. The issue about participating from out of state is just an open question I need to look into. It was, you know, not necessarily a definitive conclusion I was stating there. So.
Okay. So if we decided on March 21st right now, and it turns out that it wouldn't work, we can change that day later? Or do we have to decide for sure right now?
I think we could probably, why don't we try for the 21st? Everyone mark your calendars for the 21st, and then I'll talk to Cheryl and President Guzman and find out a little bit more on their particular issues. If it doesn't work out for the 21st, let's pick a different date and probably location. I don't know, unless we want to meet in Temecula. It's kind of an hour drive out there, so I would only go out there for the CSRC audience, maybe somewhere in San Diego or Los Angeles. So maybe like, does Friday the 29th work for everybody? Does anyone have an issue with Friday the 29th?
I don't. Anyone else?
I mean, it's a Good Friday. I don't know if that's going to.
Okay. Thursday the 28th?
No conflict here.
That works for me.
It works. Okay, so let's do mark your calendars for March 21st as the hopeful date and March 28th as the backup date. And we will try to get you something here in the next 30 days with a more definitive date.
Excellent. So then next we have June, which we would tentatively schedule a meeting if the board business requires us to meet. So the weeks marked are June 10th through June 21st. Any of those dates appeal to any of you?
Question in terms of the mode in which it's given, are we required to do all our meetings now in person?
Yes.
So certainly would like earlier of those 2 weeks than later as it gets into the summer.
All right, well, let's try June 10th. Anybody have an issue with June 10th? Monday, June 10th.
I'm just wondering, again, just going back to the March and the subsequent meetings, is it going to be in the morning similar to this one or in the afternoon?
Usually when it's in Southern California, we would like to start a little bit later to accommodate fly in, fly out same day for those who don't want to stay the night. So I would probably And I also have to work with CSRC if we have it with them, because lots of times they help us with the meeting room. You have a preference. You tell me. It sounds like you have a preference.
I mean, the morning works best for me because, I can kind of get it out of the way and get to my clinical duties.
Okay, so for both days then?
Yes.
Okay.
For all days, yeah.
Noted. Back to June. Is June 10th okay with anyone? Does anyone have an issue with June 10th?
So June 10th it is?
Okay. And that one will be tentative and it will be in Southern California. I'm sorry. That is tentative and it will be in Sacramento.
In Sacramento. Okay, so then we go to our October meeting. We're looking at dates of they're in red. October 1st through October 18th. Any preferred dates?
If we could leave out Tuesdays.
No Tuesdays. Okay. I prefer Mondays, if anybody cares.
Okay. Do we want to start with October 14th? Does that work for everybody?
Yeah, no conflict.
Okay, hearing no objections, October 14th in Sacramento. And again, we'll follow up with you on the all the board meeting dates, but we will follow up on the March one as soon as we can.
And I have a request for the March one for the backup date. If it could be in San Diego, I'm scheduled to fly out at 5 p.m.
Oh,
okay. So it's just a request, especially if it's going to be in person. Since you mentioned LA or San Diego, I'd like to throw in my preference.
Okay, and that's just for March 28th?
That's only for March 28th, yes.
Okay, gotcha.
Hey, Stephanie, I thought pre-COVID, I thought we'd had one of the meetings virtually. Is that not true?
No, we pre-COVID, we usually had one meeting in Southern California, one in Northern California, which is required. And then June was always tentative, and we actually didn't have a June meeting for a few years. And I think we might have done it by teleconference.
That's what I thought.
Yeah, that one's kind of up in the air.
Okay. Okay. Is that it for meeting dates?
Yeah, I think we just need public comment.
Moderator, any public comments?
We are now open for public comment on the agenda dates. If you would like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users, dial *3 to raise a hand. And it looks like our first comment is coming from Mary. Hold on just a moment. We're going to send you a request to unmute your microphone.
California. Hi, this is Mary Adorno from the California Association for Health Services, representing home health agencies, hospices, and home care. The discussion for the scheduled meetings, there's some confusion as to whether there will be any public comments available through a WebEx. When you had your in-person meeting, the last one you had, there was no ability to virtually attend. A lot of times there are reasons where we want to comment on just one aspect of the agenda. So coming all the way from Sacramento down to Temecula makes it very difficult. I encourage the board to have a virtual means available for your respiratory therapist that also would like to make public comment, maybe on just one portion of the agenda. It's very costly to come down to a meeting when you're just trying to hear the discussion on one agenda item. I really hope the board considers that, and I'm sure there's other special interest groups that feel the same way. Thank you very much for the work the board is doing, and especially for your work on the LVN scope of practice for respiratory care. Thank you. Have a great day.
Thank you, Mary, for your comments.
And that was our only request. Do you wish to continue with the agenda?
Yes, please. Thank you. So we don't need a motion or a vote. We can go ahead and move forward. Thank you, everyone. We will get those dates up on our website. And we're ready to move on to item 11, public comment on items not on the agenda. Please note that the board is unable to take action on any items not listed on the agenda. The only action the board may take is to decide whether to place an item on a future agenda. Moderator, is there anyone who would like to make a public comment on anything that is not on the agenda?
We are once again open for public comment, this time on agenda item 11. If you'd like to make a comment, raise a hand by tapping that hand button at the bottom of your screen. Dial-in users dial *3 to raise a hand, and we will call on people in the order we have requests. And it looks like we lost our person who had a question in the comment box.
Okay, yeah, let us know if they come back before we conclude.
So at the moment, we have no request for public comment, and we'll make sure that the board has access to the written comment afterward.
Excellent, thank you, moderator. Moving on to item 12, future agenda items. Members, do you have any specific items you would like to see on our next agenda?
Ricardo, this is Michael.
Yes. Hi, Michael.
I would like to have on the agenda Professional Qualifications Committee present or at least open for feedback from the board about the survey that we propose to send out.
Okay, sounds good. Thank you, Michael. Any others? Okay, seeing none. Moderator, any comments on the future agenda items?
We are open for public comment on future agenda items. If you would like to make a comment, tap that hand button at the bottom of the screen to raise a hand. Dial-in users dial *3 to raise your hand, and we will call on people in the order we have requests. We're going to take just a few seconds now to see if we have a request for public comment. Seeing no request, do you wish to continue with the agenda?
Yes, please. Thank you. We are at item 13, closed session. It looks like we do not have any items for closed session. And so unless anyone has any other comments or questions, we will adjourn. Okay, seeing none, this meeting is now adjourned.
Enjoy the rest of your day, everyone.
Thank you, everyone.
Nice seeing you all.
Thanks, everyone.
You too.
Thanks all. Bye-bye.
Bye-bye.
You were
We'll see you soon.